Hello students, welcome back to my channel Medicine Hub on. Today we will talk about one of the important topic regarding medicine, surgery and pathology. That means the overlapping of all these three subjects. So there is nothing but the inflammatory bowel disease, right? So all of you know that inflammatory bowel disease, it is having the two components. We can say the Crohn's disease and the ulcerative colitis, right? Now see, so we can classify we can classify the inflammatory bowel disease into two components. On will get the Crohn's disease. CD stands for Crohn's disease. Ulcerative colitis. UC means ulcerative colitis, right? Now see, in between these two diseases, the Crohn's disease and ulcerative colitis, both of them are having some similarities and some dissimilarities. Okay. So let's talk about the similarities first. So in general, the IBD or inflammatory bowel disease that is found basically in the developed countries and in the women who are taking the OCP, oral contraceptive pill, right? So what did I say? That inflammatory bowel disease is basically seen in developed countries and the women who are taking OCP. So let's write it over here. The IBD that is found basically in developed countries and number two, and the women with OCP, oral contraceptive pill. Okay, and there are some risk factors. For example, the smoking, the smokers. Okay, so another important thing over here, smoking is a risk factor for ulcerative colitis. Sorry, it's risk factor for Crohn's disease, and smoking is the protective factor. Is the protective factor for Crohn's disease. It will be ulcerative colitis. Okay, so let's correct it. So smoking, that's the risk factor for Crohn's disease, and smoking, that's the protective factor for ulcerative colitis. Okay, it's very important. Okay, now let's talk about some of the other causes. So there are some genetical causes. There may be some in the family history. There may be some genetical causes. That means in terms of the mutations of some genes, and other risk factors in terms of the different kinds of the microorganisms. Those are staying in the gut, in the intestine. So let's talk about those things. First, I'll focus over here in terms of the genetical disorders. Okay, so other causes. The genetical causes we can see over here in terms of first, the family history. There may be the mutations of NOD2. There may be okay, let's write it first. What is the full form of NOD2? Nucleotide oligomerizations domain 2. What did I say? NOD2. NOD2 stands for nucleotide oligomerizations domain 2. So it's the nucleotide oligomerization domain 2. Okay. It is ATG16 L on, and for it we'll write it over here that autophagy. Okay, let's use this code over here. So it is autophagy related, autophagy or related So it is a 16 it autophagy related 16 alone. So this is the mutations we'll get to see over here. So as I said, the NOD2 non-nucleotide oligomerizations domain 2 it is a 16 alone. So autophagy related 16 alone. We can say this is the mutations we'll get to see over here. Now, as we know that inflammatory bowel disease, basically we say in terms of the what? Idiopathic chronic inflammatory disease. It's the idiopathic chronic inflammatory disease, right? So IBD, so write it over here. It's basically the idiopathic, that means etiology is unknown, right? Idiopathic chronic inflammatory disease. Inflammatory disease. Okay, so that's the idiopathic chronic inflammatory disease. And what did I say? The idiopathic means the etiologies are not known. So I can write it over here. Unknown etiology. Unknown etiology will get to see over here. Another regions we can see over here. IG, RM. IRGM. Over here, IRGM. So another mutations we'll get over here, that is known as immune related GTPase M. So we'll get to see immune related GTPase M. So what are the mutations? The genetical causes we'll get to see. The genetical cause we'll get to see in terms of the family history. We can get to see the mutations of NOD2. What did I say NOD2? NOD2 is nothing but the nucleotide oligomerizations domain 2. After that we can get to see it is a 16 alone. So autophagy related 16 alone. And the last one, as I said, IRGM. That means immune related GTPase M. Immune related GTPase M. So these are the genetical causes where we will get to see the mutations. Now what are the other causes? So other causes or other risk factors. Here I can write also the risk factors. Now other risk factors, for example, in terms of the, if we get to see the alterations, alteration in interaction in between the microorganisms with what? With the intestine. So the most important thing we'll write over here, that alteration in interaction and between microorganisms and intestine. Okay, if we get the altered, for example, altered microbiota, so if we get to see altered gut microbiota, for example, so that means whatever the bacteria they were supposed to live over there, they have changed their what nature. For example, they at first they were the useful bacteria, right now they have converted into non-useful. That means they are not acting in the same way they are supposed to. Okay, third thing we can write it over here, aberration of immune system. If the immune system is not working properly, as I said, so sometimes it is known as also the autoimmune disorders. Okay, so in some books it's mentioned, especially in medicines, they basically mention it in terms of the autoimmune disorders. So if you get to see the aberrations of immune systems, in that case we can get to see the development of these disorders. Okay, so these are the causes we'll get to see over here. And also just write another term, that intestinal epithelial dysfunction. Intestinal renal epithelial dysfunction. If you get to see the dysfunctions of the intestinal epithelial cells, as a result we can get to see the development of inflammatory bowel disease. Inflammatory bowel disease. So these are the causes as far as the genetical causes is concerned. Other risk factors I said over here. And the other risk factors are concerned, I said over here. Okay. So if it's clear for you, now we'll go to the pathogenesis. Now we'll go to the pathogenesis. First we'll talk about the Crohn's disease. Okay. Then we'll go back to the ulcerative colitis. So let's discuss first in terms of the Crohn's disease. So first we will talk about Crohn's disease. Now see the Crohn's disease. I'm writing CD stands for Crohn's disease. Now see the Crohn's disease, as I said in the normal features, that it is also the idiopathic chronic inflammatory disease. It's also idiopathic chronic inflammatory disease. Now whatever thing we'll get to see over here, we'll get to see the involvement, rather you can say the transmural involvement of the GI layer. Transmural, that means there will be the involvement of mucosa, submucosa and muscularis propria. So what did I say? That is the transmural involvement. So we'll get to see the involvement in the mucosa, mucosa, submucosa, and the last one is the muscularis propria. So 3 layers will be involved over here. So what did I say? It is the idiopathic. Let's write it clearly. So idiopathic chronic inflammatory disease, CID. So chronic inflammatory disease over here. Okay. Now in these cases we'll get to see the transmural involvement. Transmural. Now transmural involvement means we'll get to see the involvement of mucosa, submucosa, and we'll get to see also the muscularis propria. Now see the important thing over here, that we are getting the transmural involvement. Okay. That means if I just draw, for example, is the mucosa, is the submucosa. Let's draw over here. It's the submucosa, and for example, is the muscularis propria outer one. So this 3 layers will be involved over here. 3 layers will be involved over here. The mucosa, submucosa, and muscularis propria. Okay. Now see the Crohn's disease that can be found anywhere. The Crohn's disease that can be found anywhere from the mouth till the anus. Okay, sparing the rectum. The Crohn's disease that can be found anywhere from the mouth till the anus, sparing the rectum. So what did I say? The Crohn's disease site. Where can you get to see? So from mouth to anus, anywhere it can be involved, sparing the rectum, sparing the rectum. Okay, but the most common site where we'll get to see? We'll get to see in the terminal ileum, in the ileocecal junction, or in the cecum. So where we'll get to see the most common space, the most common site, rather we can say, in the ileum, in the I'm writing IC, that means ileocecal junctions or ileocecal regions, and the cecum. Among these 3, the most common site that will be the terminal ileum. So what did I say? Among these 3, the most common site that will be the terminal ileum. So the most common site to develop the the ulcerations in terms of the Crohn's disease, that will be the ileum, ileocecal junction, or the cecum. Among these three, the most common site that will be the terminal ileum. Okay. So I'm marking with the red color over here. This is the most common site among these 3. Among these three, this will be the most common site. And in upper GI, you will get to see the most involvement. The most involvement in upper GI you will get to see, in terms of the gastric antrum, and also you can get to see in terms of the duodenum. So what did I say is very important. From here the question has been asked frequently, many times. Now what did I say? That as far as the locations of the Crohn's disease is concerned, it can be found from mouth to anus, right? But the most common site, that will be ileum, ileocecal junctions, and what did I say? This is the cecum. So the most common site, that may be the ileum, ileocecal junctions or ileocecal regions, and the cecum. Among these three, the most common site will be the terminal ileum. Among these, the most common will be terminal ileum. And in upper GIT, as far as the upper GI is concerned, we'll get to see in terms of the gastric antrum. We can get to see in terms of the duodenum. Okay, so these are the most common sites for the development of the Crohn's disease. Okay, now we'll talk about some bacteria. There are some, we can say that suspected bacteria that can develop the Crohn's disease. So what are those bacteria and some bioacids? Let's write about them. So some suspected microorganisms that can develop the Crohn's disease. So what are those? First one, the Mycobacterium tuberculous, paratuberculous, and the measles virus. So what did I say? First one is the Mycobacterium paratuberculous, paratuberculous, and the second one, the measles virus. So what did I say? There are some suspected microorganisms, okay, that they can develop the Crohn's disease. And what are those microorganisms? We can get to see in terms of the Mycobacterium paratuberculous. What did I say? Mycobacterium paratuberculous and the measles virus. These two organisms, they can cause the Crohn's disease. Okay, and in terms of the ulcerative colitis, I'll talk about those things later in the second part of this video. Okay, that will be the Clostridium difficile and other organisms also. So these are the, now we'll talk about the pathogenesis, the pathology. Okay, let's talk about the pathology. So actually what type of the pathology you'll get to see over here in terms of the Crohn's disease. And before that, just write down one information that here, what did I say? That we will get to see that not to involvement or CARD 15. CARD CARD 15 or not to. Okay. This type of the involvement we will get to see in chromosome number 16q. In chromosome number 16q. Okay. So where we get to see the mutations in terms of the CARD 15 or not to, that will be where in terms of chromosome number 16q. Okay. In the as in the long arm of the chromosome number 16. Now we'll talk about the pathogenesis of the pathology. So what type of the pathology you will get to see over here? Let's talk about those things. So once we are getting to see the development of Crohn's disease, in these cases basically we'll get to see the formation of the ulcers. We'll get to see the formation of ulcers, right? So here we get to see the formations of ulcers. And for the ulcers, we can get to see the two types of the things. We can get to see the perforation and fibrosis. So in terms of the ulcers, we can get to see the development of fibrosis. And whenever we get to see the development of the fibrosis, we will get to see the development of the stricture. So we'll write it over here, stricture. And another thing, we'll get to see the development of perforation. To see the development of perforation. Before going in details for the other things, let's talk about the one by one the pathogenesis. First, if we talk about, as we know, the most earliest, as you say, manifestations that will come over here, that is nothing but the superficial aphthous ulcer. For example, if I show over here, if I show over here, the different layers, okay, of the bowels, different part, the bowel spots in the distant locations. For example, it's also the part of the bowel. In these cases, first we'll get to see whatever the manifestations we'll get to see at first, that will be the superficial aphthous ulcer. So we'll get to see superficial aphthous ulcer. Superficial aphthous ulcer. The first manifestations we'll get to see, that will be the superficial aphthous ulcer. Superficial aphthous ulcer. The second one we'll get to see here we'll get to see that involvement of the what? Involvement of the bowels, right? For example, this bowel is involved, this bowel is involved, this bowel is involved. This is we're getting the formations of the ulcerations in these bowels. Now in between these bowels, we're getting a space where what? The ulceration is not involved. So this region that is known as escape lesions. So this region is known as escape lesions. So what is escape lesions? Escape lesions means in Crohn's disease, we'll get to see some space where the ulceration will not take place. In between the two ulcerated portions where the ulceration will not take place, that is known as the escape lesions in Crohn's disease. Okay. So this is known as escape lesions. Escape lesions over here. Okay. Now another important thing, okay, as we know, for example, it's the part of the bowel. The same way, as we know, in between the two bowels, for example, it's another bowel. Here we get to see the what? The mesenteric fat, right? Here we get to see the mesenteric fat. So these are the mesenteric fat we'll get to see over here. So these are the mesenteric fat. Now in ulcerative colitis, in Crohn's disease, whatever the things we'll get to see, there will be inflamed area over here. As a result, we'll get to see the fat regions, the mesenteric regions that will surround the bowels. So ultimately the structure that will be just like this. For example, it's the bowel portions, and here we'll get to see that the mesenteric fat that will reach up to this region, that will surround the bowels. So that is known as creeping fat. So another important manifestations in terms of the pathological aspect we'll get to see, that is known as creeping fat. Creeping fat. Okay. So this will get the creeping fat, we'll get to see the escape lesions, we'll get to see also the superficial aphthous ulcer. Okay. Now what are the other manifestations we'll get to see? Okay, we'll get to see also the halo fat. See on the diagram over here, see I have shown on the diagram, see the halo fat on the x-ray. If you get to see, we'll just look at these regions, we're getting to see that the fat around the what? Bowels, the fat around the bowels. Okay, so the fat that will be dislocated a little bit, so that is known as the halo fat. So another things over here, as I said, that will be the halo fat. It will be the halo fat. Other manifestations also will get to see that. Okay, let's show it over here. Okay, so let's continue. for it I have to erase some portions. Okay, let's erase this part. Now the most important thing we'll get to see whenever, as I said, we are getting to see the development of the ulcer. We are getting to see the development of the ulcers. Okay, so whenever we are getting to see the development of the ulcers, as a result we can get to see the fibrosis, and the fibrosis that will be converted into what is strictures. Another thing for the development of the ulcer, we can get to see the perforations. So whenever we get to see the perforation, this perforation will leads to fistula. Okay, so what kind of the fistula we can get? We can get it over here. Let's write about those things. So here we get to see the development of the fistula. For example, it's the intestine part, it's the bowel part, it's also the bowel part. For example, it's also the bowel part. Now here the diagram that will be in this way. For example, wait, let me just correct it a little bit. So what did I say, guys? So in Crohn's disease, whenever we are getting to see the development of the ulcerations, and as the ulcerations, we'll get to see the complications of the perforations. So whenever we're getting to see the perforations, we'll get to see the development of the fistula. So now see, what type of the fistula we can get it over here? Basically, we can get to see the three types of the fistula: enteroenteric fistula, enterovesical fistula, and enterocutaneous fistula. So let's show one by one. Now, for example, I'm drawing over here. One minute. And we are getting to see the superficial portions. In the superficial portions over here, we are getting to see over here the fistula. Now that will be known as cutaneous fistula. So what are the types? And at first let's write out those names, then I am going in details. Okay, the fistula we will get, the first one we'll get to see the enteroenteric fistula. We'll get to see the development of enterovesical fistula, and also you can get to see the enterocutaneous fistula. Okay, and the last one, if I want to show you the enterovesical. So for example, it's the intestine. And if I show over here the, for example, okay, let's show the different color for it. Is the colonic regions, and we are getting to see the here are the, for example, the ileums or the intestine part, and here I am drawing the urinary bladder. Now whenever we get to see the fistula in between these two as the complications of the perforation. So this type of the fistula, whenever we are getting to see the fistula in between the intestine and the urinary bladder, that is known as enterovesical fistula. This is, at first I have drawn over here, enteroenteric. That means in between the two bowels, whenever we will get to see, that will be known as enteroenteric fistula. And the first one I saw over here on the superficial layer, that is known as enterocutaneous fistula. So these three types of the fistula we can get to see over here. Now we'll go back to the clinical manifestations and what type of the changes we'll get to see in terms of the microscopic examinations. Okay, let's go for that. Now let's continue about Okay, so these are the pathogenesis as I said. Okay, we'll get to see just like these things in terms of the ulcers, where we'll get to see the fibrosis, stricture formation, perforations. As a consequence of the perforation, we'll get to see the the fistula formations, and we'll get to see the skin lesions. The first manifestations that will be superficial abscess ulcer. Okay, that's what it is written over here. Now we'll go back to the microscopic examinations. So whatever the thing we'll get to see in terms of the microscopic examination. Okay. So on microscopic examinations, whatever the changes we'll get to see in terms of Crohn's disease. On microscopic examinations, we'll get to see the extended edema. As we are getting to see the development of the inflammation or one thing, from the basic knowledge you can say, we'll get to see the development of edema. Extended edema. We can get to see also the hyperemia. We can get to see also, for example, the distortions of the mucosal lining, distortions of the mucosal lining or mucosal architecture, distortion of mucosal architecture. The most important thing, we'll get to see the development of non-caseating granuloma. This is very important. Okay, so that's why I'm writing with a different color. We'll get to see the non-caseating granuloma development. Okay, now let's talk about the clinical manifestations, right? So see, whenever we are talking, try to understand, whenever we are just saying that we are getting to see the development of the ulcerations. So as a result, we will getting to see the fibrosis or the stricture formations. So whenever we get to see the fibrosis or as a consequence of the fibrosis, we will get to see the development of the stricture formations. So we will get to see the partial blockage of small bowel. So here, for example, if we say over here, okay, so we'll get to see the development of small bowel obstructions, partial small bowel obstructions. So whenever we'll get the small parts, small bowel obstructions partially, or we can say rather the partial small bowel obstructions. So definitely we'll get to see the development of abdominal colicky pain, and we will get to see also the diarrhea, intermittent diarrhea. So what are the manifestations we'll get to see over here? Let's write about those things. So in terms of that clinical manifestations, I write it over here once again. The same important things that as we are getting these things, that means as I said, the stricture formation, the fibrosis. So we'll get to see the small bowel obstruction, you can say the partial small bowel obstruction. Okay, as a result, we'll get to see the colicky lower abdominal pain, and also we'll get to see the development of diarrhea. So diarrhea, that is nothing but the intermittent diarrhea. Here we'll get to see the very few. What? The movements. Why the bowel movement will get to see the very few? Because see, if it is, for example, if it is the ulcerative colitis, where we'll get to see the development of rectum. Now from the rectum, by the backward, if we say in the backward regions, we'll get to see from that regions the bubbles that will come in the upward directions. So that's why in that cases we'll get to see the bowel frequency. We'll get to see the frequency of the bowel, that will be more, but in these cases the frequency of the bowel movement, that will be less. So in terms of the clinical manifestations, so here we get to see the small, or you can say rather that bowel movement, that will be less. Now see on the diagram, if I show you over here, see, here we get to see the stricture formations. Here see, the stricture formation is given over here. Okay, so Ultimately, we'll get to see the development of the small bowel obstructions. As a result, we'll get to see the development of abdominal colicky pain. So we'll say in the better way that the lower abdominal colicky pain, and that will be more than the diarrhea. And in very few cases, rather we will say it's very rare that along with the stool we'll get to see the mucus or the blood. So it's very rare. Rarely we'll see we'll see the stool that will be with blood or mucus. Anyway. So in the rare cases we'll get to see the stool that will be along with the blood or mucus. Okay. So these are the clinical manifestations we'll get like in this ways. And let's talk about right now the diagnosis. How can we diagnose the Crohn's disease? Okay, let's talk about those things. Okay. Let's talk about the diagnosis. And one more important thing, if you want to remember, you can remember, but from here the questions are not asked basically. So if you want to remember, you can remember that in Crohn's disease, what did I say? The most common site that will be the terminal ileum. So in terminal ileum, whatever thing we'll get to see? We'll get to see the development of the stricture formations, perforations, the fistula development, and also, what did I say? That's the most important thing. We'll get to see the small bowel obstruction in the most commonly seen, that will be in the terminal ileum. Okay. And another important thing in terms of the clinical manifestations, we'll get to see sometimes within the anal regions. So in the anal, we can get to see the anal fistula, anal abscess. Okay, we can get to see the anal fistula, we can get to see the anal abscess, we can get to see the anal stricture. So as far as the anus is concerned, we can get to see this type of the manifestations within the anus. Okay, now let's talk about the diagnosis. Now see, as far as the diagnosis is concerned, the investigation of choice for diagnosis of Crohn's disease, that will be CT enterocolitis. So CT enterocolitis, this is the investigation of choice as far as the Crohn's disease is concerned. Okay. And there are some radiological investigations also. Radiological investigations. Okay, let's talk about those things one by one. First, I'll just talk about that long hosepipe stricture. We'll get to see the development of long hosepipe stricture. Okay. So the first thing, long hosepipe stricture. What did I say? That means if I just show on the diagrams over here on the diagram, whenever we get to see the ulcerations formations, as a result we'll get to see the fibrosis, and the fibrosis that will leads to what? The fibrosis that will leads to structure formation. And when you are getting to see the development of this structure, and these structures from the both sides of the ileum, from the both sides of the ileum, they are giving the development of hosepipe like structure. For example, if I show over here, this is the terminal ileum, this is the terminal ileum from both sides. It will be in this way, inflamed regions, and in this region, in between these two regions, we'll get a structure that will look like the hosepipe structure. The long is the long, of course, is the long hosepipe structure development. Okay. And it is also known as characteristic features, that is known as also that sign of the Cantor. So what did I say? String sign of Cantor. So you can remember if you want to remember. String sign of Cantor. So string sign of canter. So this is the manifestations we'll get. The long host pipe structure. As I said already before, that we'll get to see that what? We'll get to see the halo fat. We'll get to see on the radiological aspect, we'll get to see the halo fat. Also, we'll get to see in these cases that, for example, let's so over here. Okay, that's known as, okay, let's show which part. Okay, I'm showing over here. That's very important one. Okay, I'm going to say right now. Another important sign on the radiological aspect we can get to see that is known as rose thorn appearance. Rose thorn appearance. Actually, the pathologist they just gave this name. So rose thorn appearance, that means we'll get to see the linear transmural ulcerations. So for example, if it is the bowelic regions over here, so in these cases we'll get to see the development in this way. So see, these are the linear transmural ulcerations. So these are linear transmural ulceration. Linear transmural ulceration. Linear transmural ulcerations, and that is known as transthorn appearance. Transthorn appearance. So what did I say? On the radiological aspect, we'll get to see the long host pipe structure, and that is also known as the string sign of canter. The string sign of canter. We can also get to see the halo fat. We can get to also see the what? Linear transmural ulcerations. Another is known as comb sign. Okay, let's write it over here. So what is comb sign? See over here. I'll show on the X-ray. Okay. See on the over here. So comb sign basically will get whenever we get to see the vascularizations of the ileum. So let's write it over here first. Then I'm going in details. Okay. I think you have written up to this much. So I'm erasing this part. So comb sign is nothing but vascular jejunizations of ileum. Jejunization of ileum. So that is the thing where we get to see the development of the comb sign, vascular jejunization of ileum. Okay, so these are the manifestations on the, as far as the radiological aspect is concerned. We will get to see the development of this type of the conditions. Okay, and there are some serological markers. The PNK, the PNK is responsible for the detection of, basically we use the PNK for the detection of ulcerative colitis. But as far as the Crohn's disease is concerned, as our current topic, so for that thing, the serological markers, that will be the ASCA. Okay, so let's write it over here. What are the serological biomarkers for it? Okay, what should I write? Okay, so what are the serological markers? What are the serological markers we'll get to see over here? Now see the serological markers. Here I will write it over here. ASCA. ASCA, what is the full form? Anti-sarcomyces cerevisiae antibody. Now this is the serological marker for what? Crohn's disease. But another important thing you will read that the PNK, antinuclear cytological antibody. PNK, that is for ulcerative colitis. That is for ulcerative colitis. Okay. So these are the serological markers we'll get. Okay, by which we can just make sure yes, the individual is suffering from ulcerative colitis or the individual is suffering from Crohn's disease. Now, the another most important thing, that is what are the extra intestinal manifestations? What are the extra intestinal manifestations we'll get to see in Crohn's disease? From here, frequently questions have been asked, made. Okay, so let's talk about those things. Now I'll just erase this portion. So what are the extra intestinal manifestations? Okay, that's why I'll just take a place over here. So what are the extra intestinal manifestation? First, the most important thing, whatever the manifestations we'll get to see in the skin. So in the skin, we can get to see the development of erythema nodosums, okay, erythema multiforme, and pyoderma gangrenosums. So as far as the skin is concerned, whatever the manifestations we'll get to see, we can get to see the erythema nodosum. We can get to see the erythema multiforme. We can get to see the pyoderma gangrenosum. So these are the manifestations we'll get to see as far as the skin is concerned. Now we'll talk about what are the manifestations we'll get to see as far as the ophthalmology is concerned. Okay, within the eyes. So within the eyes, as the extra intestinal manifestations, we can get to see the development of iritis, inflammation of the iris. We can get to see the development of uveitis, the inflammation of the uveal tract, and also we can get to see the inflammation of conjunctiva. That is nothing but it's simple conjunctivitis, right? Conjunctivitis. So these are the manifestations we'll get to see as far as the eyes are concerned. Now we'll talk about what are the manifestations we'll get to see as far as the livers are concerned, the hepatobiliary system is concerned. So when you are talking in terms of the liver, first we'll get to see the development of primary sclerosing cholangitis. Basically this thing is basically found in most of the cases in terms of the ulcerative colitis, but this primary sclerosing cholangitis, that is also found in terms of the Crohn's disease, but mostly it is found in case of ulcerative colitis. Second, we can get to see the development of cholesterol stone. Now that's very important. Cholesterol stone, so we get to see the development over here. Now, as we know that the Crohn's disease is the disease of the terminal ileum. So whenever there is a terminal ileum blockage over here, for example, the inflammations, of course, that can leads to the blockage over here. Now the intrahepatic, if I say the intrahepatic circulations of cholesterol, that means of the bile acid and the bile salts, that will be inhibited. So what did I say? As the Crohn's disease, that is the disease of the terminal ileum. So whenever there will be the problem at the terminal ileum, okay, there will be the inhibitions of intrahepatic circulation of bile acid and bile salt, and that will lead to the development of cholesterol stones over here. Okay, now we'll talk about what are the manifestations we'll get to see in terms of the kidneys. So as far as the kidney is concerned, there will be the development of the nephrotic syndrome. Another important thing, it can also lead to the amyloidosis within the intestine. Okay, amyloidosis. Okay, so liver is done, liver, kidney, eyes, skin. Okay, and what is left over here? Let's talk about the last part, urological. Yes. And what type of the manifestations we'll get to see in urological? Now, urological, here we'll get to see basically the formation of the stones within the ureter, or urolateral, ureteral obstruction. You can get to see the first thing I write it over here, that you can get to see the development of the stones. And the stones, basically what type of the stones we will get to see? What? That is the oxalate, calcium oxalate. The second thing, we can get to see the ureteral blockage or ureteral obstruction. Ureteral obstructions can also be seen as far as the urological manifestations are concerned. And within the pancreas, as far as the pancreas is concerned, it might be seen the pancreatitis. Okay. And the most important thing is in terms of the treatment. What did I say? Yes, where? Yes, erythema nodosum. Erythema nodosum is a condition. Okay. It responds very fast. It responds very fast in the treatment of ulcerative. In the treatments of the Crohn's disease, the erythema nodosum. Now think about this thing, that an individual who is suffering from Crohn's disease, and he is also under which therapy? Under the therapy of Crohn's disease. Now, if we don't get to see that responsiveness of the erythema nodosum, that means the disease is not under control. Okay, that means the therapeutic use that is not able to fight along with the disease. That means ultimately we can get to see over here if the responsive is not over here, that means there is no development in the treatment. There is no development in the treatment. So these are the different kinds of the manifestations, the different kinds of the the pathogenesis and the causes and the normal features. Now in the next part of the video, we'll talk about the treatment. Okay, in the next part of the video, at first I'll talk about in details about the ulcerative colitis, and the second part, along with after that, I'll just discuss about the treatment for both, for ulcerative colitis as well as for Crohn's disease. Okay, so thank you for watching. If you don't understand any point related to this video, please let me know in the comment sections. I'll try to help there, guys. Thanks for watching. See you soon.